Hello everyone, myself Medical Ghost. Indeed, it sounds like an interesting case today. The 55-year-old male patient with hand swelling and joint pain involving both proximal and distal interphalangeal joint. That was symmetrical involvement and that was like inflammatory joint pain. And he was received a conflicting diagnosis of RA or osteoarthritis. The and he had like this type of skin involvement, joint involvement, is swelling in the joint. Another very important finding also there, but I will mention it later. And the X-ray showing some distinctive finding that I will describe later. On observing the X-ray and the skin finding and the joint finding, we thought a diagnosis, and we thought to ask for any skin lesion. But the patient initially denying any skin lesion. Upon repetitive history taking, he revealed a past misdiagnosed eczema-like skin lesion that was unfortunately treated with local antifungal. With confirmation from the dermatologist, we conclude that this is a case of plaque psoriasis. The skin lesion is here, and we confirmed our diagnosis as psoriatic arthritis in a background of plaque psoriasis. So we took help of Caspar criteria for diagnosing the psoriatic arthritis. Now coming to the discussion point. So this case is very much important for a NEET PG aspirant and a final year student who are looking for the sport case and dermatology and medicine residents also. So we'll discuss this case along with some theory. So psoriatic arthritis in 70 to 40% psoriatic patient develops psoriatic arthritis. So this incidence is common in generally male than female, and some texts also recommend that male and female has same incidence. It occurs generally 30 to 55 years. In this case, the patient is a male patient and his age is 55 years. And look carefully, there is a symmetrical involvement of the hand joint and predominantly involving distal interphalangeal joint. That suggests that is a case of psoriatic arthritis according to Wright and Moll criteria. So some textbook also recommend that asymmetrical oligoarthritis is most common presentation of psoriatic arthritis. But some rheumatology textbook is recommending that symmetrical polyarthritis is most common presentation in psoriatic arthritis. And you can also observe that dactylitis, that is sausage shaped finger. So this is very much specific for psoriatic arthritis. We have to rule out HIV. And nail changes, almost 100% patient of psoriatic arthritis have nail changes. That nail changes like pitting of nails, onycholysis like yellowish discoloration of the nail, hyperkeratosis like horizontal ridge, and that hyperkeratosis is dystrophic hyperkeratosis. And also have some oil drop signs. Unfortunately, that is not captured here. X-ray finding may include pencil in cup deformity, marginal elevation with adjacent bone formation, that is also known as whiskering sign, small joint ankylosis, osteolysis, telescoping of joint, that is also known as ivory phalanx, and most characteristics like ray pattern of joint involvement, that is all the three joints like DIP, PIP, MCP joint involved, like a ray or row pattern that is seen in psoriatic arthritis, also seen in RA. And so this is a skin finding that demonstrating like a plaque psoriasis, typical finding of plaque psoriasis. And according to the Caspar criteria, we diagnosed this case as psoriatic arthritis. So Caspar criteria matches with current psoriasis that accounts for 2 point. Typical psoriatic nail changes, dystrophy was there, and patient has negative RA factor. Patient is having dactylitis or a sausage-shaped finger, and there was radiological evidence of extraarticular new bone formation. So all these accounts for the diagnosis of the psoriatic arthritis according to Caspar criteria. And We also examine for HIV test and liver function, CBC, and other routine examinations. And we also ordered an echo to rule out aortic regurgitation that is common or that is may associated with psoriatic arthritis, aortic regurgitation, and aortitis. But on auscultation, there was no murmur. Coming to the treatment part, anti-TNF alpha is considered a drug of choice, that is the mainstay of the treatment. But considering the cost of the drug, we prescribe tablet methotrexate, and we refer to dermatologist for the management of the skin lesion.